I'd like to invite now Professor Greg Dore to speak to us. Professor Dore is the head of viral hepatitis clinical research program at the Kirby Institute at UNSW and is also an infectious disease physician. And he and I had a little bit of a conversation prior to today about what he's going to discuss, and I think it's going to be very complimentary and of great interest, building on what Teresa's done. So please, Greg, take to the stage.
Thanks very much, Eric, and it's a great pleasure to present, it really is. When Susan asked me to give a presentation, I think it was around about June maybe, and I thought this would be pretty straightforward, self-congratulatory sort of presentation on how well Australia had responded to the epidemic. And then we saw what happened in July and August in Victoria. And I think, complacency was a word that was used very often. But I think there's some further sort of lessons that we really have taken from what happened in Victoria. And I think in the long term, having had that second wave, so to speak, maybe not such a bad thing for Australia in terms of where we go forward. So I just want to take you through a range of sort of aspects of COVID-19 from a sort of broader public health perspective. I know unprecedented times is tired, and I know Peter said historically it's not particularly accurate, but it certainly has been used a lot. We have had other sort of major respiratory virus pandemics, obviously 2 other coronavirus epidemics, SARS and MERS, and the H1N1 influenza epidemic that did affect Australia. So we have had a relatively recent respiratory epidemic, but it has been different. So there's been relatively limited impact from these previous acute respiratory epidemics, and there certainly has been mask-wearing inexperience. Now, I think New South Wales still has mask-wearing inexperience, certainly compared to Victoria. And I think the Victorian experience is a lesson, I think, in terms of community mobilisation around sort of a preventative measure that's really important. Phenomenal pace of knowledge creation versus an incredibly concerning culture of misinformation. The elevation of public health, epidemiology and infectious diseases. So someone who works in those areas, it's been great to sort of have that, those areas more prominent in society. But, and it's already been spoken about, the sort of really pivotal role of chief health officers. But you have at one end Brett Sutton pillows in Victoria, the other end death threats for Jeanette Young in Queensland. So it's been a really sort of troubling time for people that are community facing in such a sort of a major way. And the tension between sort of public health and economic priorities in relation to wellbeing is clearly sort of played out. It's been a year of exposure, and I would say overexposure. As someone who sort of moved in a relatively small sort of pond of hepatitis C, where a few people knew what I did, but now my neighbours know what I do. And I think everyone knows who Raina is. Raina's a bit like Beyonce, Kylie. You say the first name and everyone knows who you're talking about. Gail Matthews is a colleague at both the Kirby and St Vincent's, and that's part of a Women in Science and Medicine Vogue sort of profile. So really public health people and clinical people have really been in the community minds and community sort of exposure through the last sort of several months. And there's some good things about that, but there's some issues we have to deal with as individuals because of that. Certainly been a big year for social media. Again, I've been on Twitter for a few years, but again, a relatively small player talking about hepatitis C and health for people who use drugs, which is my major passion. But then COVID came along and there was a real sort of need in terms of community education and engagement through different platforms. And I've actually really enjoyed that communication. But when we talk about the biggest tweeter, or some would say the biggest twit, Donald J, it really has been interesting to follow the sort of US-based social media coverage and the polarisation of information and opinion. And I think his infection is really interesting because I see it as a sort of microcosm of the failed US public health response. So certainly poor adoption of prevention measures, haphazard testing strategy in terms of what was happening in the White House, limited contact tracing, and over-reliance on unproven therapies. and an absolute sort of indication of a two-tiered healthcare system. I mean, I was in the US this time last year, visited Philadelphia and visited sort of areas of Philadelphia where there's lots of homeless people and people who are injecting drugs. And I came away absolutely sort of gobsmacked. And I always knew that there was a two-tiered system, but I gave a presentation at the University of Pennsylvania Medicine and a big shiny private hospital, and then went to the streets. And that sort of gulf between the haves and the have-nots is really quite frightening in the US. So what are some of the lessons from COVID times? I think COVID-19 holds a mirror to public health systems and finds any weaknesses, and I think that's really sort of played out. The flattening the curve sort of concept that we originally had to try and sort of prevent the overwhelming of our public health, particularly acute hospital sort of systems, it works to a point, but you really do need major community transmission control. I sort of jumped on the elimination bus, and the suppressionists and eliminationists had a bit of a sort of battle for a while there. But I think we're all on the same page in terms of the strategy being trying to get as great a sort of community control transmission that we could achieve. And I think one of the lessons from this will be that that is best for health outcomes, and it's also best for economic outcomes. Australia has benefited from the federal system of government. I think having the jurisdictions able to implement their sort of healthcare policies and their prevention sort of strategies is a good thing. And one of the things I was most concerned about was the initial national leadership, which I thought was really impressive, the coordination, the bipartisanship around that. But that has sort of broken down somewhat in recent sort of months. And I think the undermining of Dan Andrews' sort of strategy in Victoria by certain sort of senior Liberals was a major, major concern. So New South Wales is clearly a leader in surveillance and public health implementation, as Teresa sort of outlined. I had to add a little bit just recently, but VIC closing rapidly, because I think what they have done in Victoria over recent sort of weeks and months is really very, very impressive. And look, they've taken some lessons from New South Wales undoubtedly, but it's great to see the response that they've had. Again, as Teresa sort of outlined, vulnerable populations have been protected with some key exceptions. So as someone who works in terms of their care, giving in the context of vulnerable populations, people who inject drugs and people who are homeless, it has been amazingly rewarding to see those populations largely protected. And undoubtedly, prevention is king and queen. With false hope around miracle cures, I think people don't really understand how difficult it is with an acute respiratory viral infection with a very short period of viremia to get effective antiviral therapies to have any impact. And I think what's really sort of played out is how ineffective those sort of therapeutic interventions have been. And so prevention absolutely is the key. Just some sort of stats from around the world. I think people are probably aware of that, so I won't spend any time on that particularly. Just to say, at St Vincent's in Sydney, we've had around about 200 infections and no deaths, thankfully. And only 12 hospitalisations amongst those 200. The infectious diseases department was the sort of first point of call for people that were swab positive through the St Vincent's screening clinics, both in hospital and pop-up clinics. So it was great for us to actually have that communication with people in the community, to sort of phone them, talk to them, and then talk to them sort of regularly. And that helped us set up a cohort that followed people both from the hospital, but largely people who were being managed in the community. And I'll talk just very briefly about that in a minute. I'm not going to go through this in great sort of detail, but I did want to point out a couple of things in terms of the natural history of COVID-19. So around about 5 days following exposure, on average, is the presentation of symptoms, and we think about 2/3 of people develop symptoms, maybe a third are asymptomatic, although there's still some sort of work to do to refine that. And that incubation period can vary from 2 to sort of 14 days, but it's this sort of short-term viremia, I think, that is really sort of pivotal in terms, as I said before, the lack of sort of therapeutic intervention effectiveness. Look, there may be things that come through that are going to be effective, but it's very different to a chronic viral infection, HIV, hepatitis C, where the sort of adverse outcomes are many years down the track, and you can suppress the virus or cure the infection and really turn things around. It's also very different in terms of that symptomatology to SARS and MERS. So SARS and MERS, in terms of symptomatic infection, they develop symptoms and then their highest sort of viral burdens in the second week. So that's why SARS and MERS are actually much easier to contain. So people were symptomatic before they had really very high levels of virus and were very infectious. So that's why this is somewhat more difficult, obviously, to contain. Everyone knows about the age-specific nature of certainly the mortality side of things, and really remarkably sort of exponential sort of increase in terms of age-specific mortality. Again, there's been a lot of discussion, debate around what's the infection fatality rate sort of globally, but it varies enormously by the country's age distribution of the affected population. So you go to Africa and people say, why haven't there been more deaths in Africa? Well, a lot of countries in Africa have a median age of 20. Versus Australia and European countries where the median age is decades above that. And that really sort of dictates, so to speak, what the infection fatality rate will be in the individual country. So these are the cases in Australia. You can see that first sort of wave, and although epidemiologically you shouldn't call it a second wave, everyone's sort of come to that sort of terminology, the second wave in Victoria. And a very sort of different sort of epidemic in a sense, the first versus the second. New South Wales has largely had an epidemic that's been overseas acquired. And you can see here the breakdown in terms of the proportion overseas acquired, and Teresa's had the job of managing a lot of those. But even at St Vincent's, the majority of the cases that we've diagnosed has been among people that were travelling. And that is very different socio-economically to the Victorian epidemic. And the Victorian epidemic certainly spread more into areas of lower socioeconomic sort of class and a broader sort of community-based sort of spread. So different issues in Victoria versus New South Wales. And these are the cases in New South Wales by mode of acquisition, overseas versus local. And we had eliminated community transmission in New South Wales in May. There's absolutely no doubt about that. We had several weeks where we only had a few positive cases that in hindsight were almost certainly false positive cases. And then we had the crossroads moment, and then since then we've been battling away against various sort of clusters. But we've been doing it pretty well in terms of overall sort of management. And one of the remarkable sort of things has been the increased capacity of testing and the way that the community's been on side and come forward for testing. So it's interesting to go back to sort of April, which was the height of the first wave, and look at the number of tests that we were doing in New South Wales versus the number of tests we're doing sort of in the last sort of 3 or 4 months. Really quite incredible level of testing and the support, as I said, of the community behind that testing. It's interesting the impact of restrictions that we had from late March on other respiratory virus infections. So this is data from the St Vincent's lab, and at St Vincent's we use a multiplex PCR system, so we test for 17 different respiratory pathogens. So everyone who has COVID-19 also gets tested for other human coronaviruses caused the human cold, rhinovirus and various other respiratory pathogens. In the red is the COVID-19 positive, in the blue, the height is the rhinovirus. And you can see all these respiratory viruses coming down as people just stayed apart. So restrictions, not surprisingly, work in terms of transmission of all respiratory viruses. So really quite impactful. But you can see how rhinovirus sort of surged back once kids went back to school, once there was a easing of some of the restrictions. But thankfully, we'd got COVID-19 under such good control before that easing occurred that we didn't get the sort of rebound that we saw with rhinovirus. And influenza just hasn't been an issue in New South Wales or Australia. And this is the data in terms of positivity for influenza in terms of swab tests. There's been a lot of concern about, well, what about the other impacts? Because of the changed sort of nature of delivery of healthcare services, what sort of happened. But there hasn't been any increase in overall mortality. Even if you look at areas such as cardiac disease or cancer, certainly data through to the middle of the year, there was no sort of impact. There was a reduction in fact, in terms of deaths related to respiratory disease. And that's not because we've done just so well around COVID-19, obviously, it's because of what I showed before about all the respiratory pathogens and the decline that they've been done through restrictions. Teresa sort of mentioned about sort of contact tracing in New South Wales, and it really has been quite remarkable. So since that sort of crossroads hotel moment that we've had this ongoing sort of battle against sort of various sort of clusters. And this just shows the cases that are linked in terms of clusters throughout that sort of period through July, August and to today. And this sort of system of sort of exposure to infection, to testing, and then what follows in terms of contact tracing. And one of the advantages that we have in Australia has been that the sort of time from symptom onset to testing, the median is 1 day. And then from getting your test done and getting the result back, the median is less than 24 hours. In the United States, they've done some research recently, and it's 6 days from symptom onset to getting the result back. 3 days to get a test, 3 days to get a result back. Forget about contact tracing in the context of those sorts of delays. Forget about the ability of testing to really help control the epidemic when you've got that sort of a system. That's public health that's completely fallen apart. And the sort of, again, going back to the hotel quarantine sort of issue, this is a PCR-based swab testing that's been done through the hotel quarantine system. You may not be completely aware, but initially people were only tested with symptom onset, and then the policy was changed to test people at day 2 and day 10 is the standard sort of procedure now in terms of anyone in hotel quarantine. And it's been a system that, as Teresa mentioned, has been incredibly successful. Protection of vulnerable populations, the Kirby Institute has led a project that's been funded by the Commonwealth to roll out rapid point-of-care technology to rural and remote Indigenous communities around Australia. So 85 communities are covered by this program. So in a community where if you had a swab test, it might take a couple of days to get sent to the central lab, get the result back, you now have a test that can be done within 45 minutes to get the result back. So the capacity that that has to really assist the whole sort of isolation, quarantining requirements around suspected cases has been really remarkable. So again, I'm very proud that Australia has sort of taken this as a priority. I think the Victorian sort of healthcare worker sort of experience is something that's been very sobering in terms of the number of healthcare workers that have been infected. So more than 3,000 healthcare workers in Victoria have acquired COVID-19. And you can see here in the curve the sort of numbers of cases on the right and the community cases. And you can see when they were starting to decline, the healthcare worker cases were still sort of occurring, not surprisingly, because they were the facing at-risk population in terms of caring for those people in the healthcare system. And look, there's been a lot of discussion about PPE and mask wearing and N95 masks versus surgical masks. And I think a lot of learnings will come out of this in terms of the Victorian healthcare worker sort of experience in terms of best practices going forward. This is a nice sort of demonstration by Ian Mackay, as a virologist from Brisbane, about what's required in terms of overall sort of epidemic control and prevention strategies, and making the point that some of these are personal sort of responsibilities, some of them are shared responsibilities or broader sort of governmental or community responsibilities, and we can't just rely on one sort of strategy, and that we have to have a sort of combination of strategies. When the prevalence is high in the community, you do need, I think, broad mask wearing. We've been very fortunate in New South Wales. We haven't had high community sort of prevalence for a very long time. But you need testing strategies that are really responsive. Obviously, you need community support for those testing strategies. You need political leadership. You need a whole range of other things that come together. So where are we sort of headed in terms of future directions? Vaccines are on the horizon. There's 11 vaccine candidates in phase 3 evaluation, but I think a lot of people in the community are not aware that they almost certainly will not prevent infection. So they're not going to provide sterilising immunity. we're hoping that they're going to prevent COVID-19 disease. They'll stop people getting sick. Okay, so that's what we want from these early candidate vaccines. Post-COVID illness, or what's been described now as long COVID, a term that came from the affected community, clearly needs further characterisation, and we're involved in some of that work. Lots of discussion around an Australian sort of Centre for Disease Control, some pros and cons about that. I'm sure some people at the jurisdictional level not really happy about some of that discussion. I'm not sure what sort of side of the debate I'm on at the moment, but certainly something worth sort of discussing. I think Australia moving closer to Asia is one hopefully future direction. I think about mask wearing. It's so normalised in most parts of Asia. I hope it becomes a strategy that we can implement when required in a much more sort of normalised fashion. And we've talked about how working arrangements have been altered. It's pretty remarkable sort of looking at just the numbers across US states and then European countries, and this is sort of population, cases by population sort of rate. And then you've got Asia and Pacific sort of down the bottom and hardly sort of, hardly seeing any sort of blips there. It's sort of frightening when you look at the numbers. I think I calculated it last week, the number of cases that they had in Belgium on one day. If you translated that to the Australian population, it would have been 38,000 cases in one day in the Australian population. It's hard to get your head around that level of community transmission. We've been very fortunate. Just very briefly, we're doing a study at St Vincent's where we're following people with post-COVID illness for a range of different aspects, neurocognitive function, lung function, mental health, looking at quality of life, obviously, and looking at antibody development and sustainability of antibody responsiveness, a whole range of immunological markers we're looking at, and a qualitative, really neat qualitative sub-study. Just some very sort of preliminary data. And the message from this is that there's around about a third of people who are managed in the community, so not hospitalised at all, and the large majority, in fact 90% of this cohort, we've got around about 130 now, were managed in the community. So 2 to 3 months post-infection still have some symptoms. So we're obviously following them more closely as we go forward. So, I mean, just a final sort of point. Hopefully life will return to somewhat sort of normal. As a parent of a 16-year-old child who had his first crowd surfing experience late last year, I'd be very upset if he couldn't go back to that. And it's been not a time that's been incredibly tough for him. He's had a surfboard he can get on and sort of and easy sort of anxiety that way. But you do sort of feel for kids, I think, at this sort of stage in terms of what the future holds. Just some acknowledgements in terms of the people involved in the ADAPT study at St Vincent's Hospital. It's been a great sort of project to be part of. Thanks very much for your attention.